friends, and welcome to the Medical and Health Roundtable for the World Humanitarian Forum. COVID-19 has impacted every aspect of the society around the globe. It's shown the variety of responses from different governments at all levels, and it's exposed challenges and issues in providing health services. Today we've assembled a preeminent panel of experts who will talk about COVID-19, humanitarian health services, and the future of our world. So I'd like to introduce first the panelist is Samuel Bichimo, who will introduce himself and then we'll introduce everybody else. Sam?
Thank you, Professor Donald. My name is Samuel. Normally I'm called Sam. I come from Kenya. Actually now I'm in Nairobi, so good evening or good afternoon, wherever you are. I hold a diploma in clinical medicine and surgery from the Kenya Medical Training College, currently working with the Africa Medical Research Foundation as a coordinator of one of the projects in the counties. At the same time, I'm an international board member of Medicine Sans Frontiers, based in Geneva. I'm also affiliated with the Sea Change Initiative, not a very old small NGO based in Canada that is actually focusing on community empowerment. Happy to be here. Back to you, Donna.
Thank you. Dr. Patel.
Hi, my name is Vikram Patel. I'm joining you from Mumbai in India, the epicenter of the global pandemic right now. I'm a psychiatrist. I'm a professor of global health at Harvard Medical School, but I also have spent the last 2.5 decades working mostly in India, but also in many African countries, working primarily with partners in these countries in India with an NGO that I co-founded way back 25 years ago called Sangha. Thank you.
Rebecca Herman.
Thanks, and thanks so much for having me here today. I'm a midwife with specialization in perinatal care for survivors of trauma and women living with other contexts that create sort of acute response. I've been working with Pathfinder International for the past 8 years, supporting countries throughout Africa and South Asia on a range of women's health interventions, capacity building and training initiatives. And then, as with many other people, this year has been a year to pivot toward addressing everything the pandemic has brought up, and have been working with the Global COVID Perinatal Task Force out of the University of British Columbia, as well as working to support sort of response efforts in various countries, including here in the US, on how we maintain essential services during the pandemic. Thank you.
Thank you. Dr. Abramowitz.
Hi, everyone. How are you doing? So I just want to say good morning and thanks to the forum, the organizers, and Elena Charapana for bringing me into conversation with this extraordinary panel. I'm a medical anthropologist, a sociologist, and an epidemiologist who's been working on the real-time integration of social science into pandemic response since the West Africa Ebola outbreak of 2014. Currently, I'm working with UNICEF Headquarters Communications for Development, C4D unit, to support the global risk communications and community engagement pillar of the COVID response, and to scale the new interagency minimum quality standards and indicators for community engagement that I co-authored under UNICEF's leadership with Jamie Bedson over the last few years. So thank you for having me.
Thank you. And last but certainly not least, Dr. Hauptman.
Oh, thank you very much. And I want to start off by saying that I'm absolutely thrilled to be participating in this roundtable today, particularly with my fellow discussants, who is just a formidable group. My name is Dr. Bill Hauptman, and I'm a medical director with International SOS. I'm sitting here now in Philadelphia, but we have offices and assistance centers in 26 locations around the globe. We are the world's largest medical and security assistance company, operating globally now for more than 35 years. And of course, like everybody on this panel, we have pivoted dramatically to COVID-19 since around February or March. There has been a lot of business as usual in our NGO travelers and other travelers but International SOS has had, I can say, an unprecedented response to the pandemic in terms of harnessing our global resources to the advantage of our members to understand what's happening globally and to be able to provide advice and support from the very beginning of the pandemic through to the current time period, where we are beginning to assist our NGO members as well as other members in thinking about returning to site, returning to their missions, and returning to travel. Thank you.
Thank you. We have a list of questions and other questions I'm sure will come in from the attendees today. I will direct each question to one of the panelists, but I invite other panelists to chime in, when there's affinity there to the answer. My first question is, the impact of COVID-19 has been significant across every sector of society. What have been the primary challenges for humanitarian health services? Dr. Buchimo.
When you talk of humanitarian work, you are talking about people, you are talking about cargo. Cargo, by that I mean medical supply, pharmaceutical and pharmaceutical. You are talking about medvac. So with COVID and the restrictions that came with it, when you're talking about the global restrictions, so the access to the field of humanitarian space actually shrinked or was not there at all. So this gives a very, I would say, an unprecedented consequence for the beneficiaries of all the humanitarian activities that whichever organization is doing. And this actually conflicts also with the interests of the particular NGO, because now it has to go to its own priorities. So this means actually there has been a lot of lack of access to the general healthcare, prioritization of what actually the intervention that was normally there. So it was now focused on life-saving at the expense of the other conditions that are usually there. So this has posed a big reflection on actually if we are all fit for purpose in case of such a pandemic. We are living in this now. It's a challenge, but I think the most important thing is what lesson are we drawing from this impact on the humanitarian work that has been brought by COVID. There's also something else that is very, very, touching, the reliance of humanitarian work from abroad. So meaning that the workforce, most of the countries actually are relying on imported workforce. So meaning there's, when their staff are either evacuated or they are sent to quarantine because they were exposed to a suspect case, then you leave a gap in your routine work. And it goes far beyond, and not just in focus, but impacting on actually even the outputs that you had already planned in the beginning of your program or your project.
Thank you. I think the entire panel, what has this shown about challenges in coordination and capacity of the international health system?
Well, at International SOS, we've seen that the health infrastructure in many countries has been really dramatically affected by the pandemic. In the Philippines, in many countries in South America, and even in European countries at the beginning of the pandemic. And I think the implication of that is that it's more critical than ever that when NGO workers or even people who live in that country are working, that everything possible is done to optimize their health, before they leave on a mission or while they're in the country, optimizing not just physical health, pulmonary disease, cardiac disease, but also mental health, so that while people are abroad, particularly in countries where the health infrastructure has been dramatically impacted, we want to decrease, mitigate insofar as possible, the chances that we will have to avail ourselves of that healthcare system. Firstly, because it won't be easy and the access may be decreased. And secondly, because we know that we don't want to take a bed away from somebody else who may need it more dramatically. And the other implication, of course, if we're going to be operating in countries where the health infrastructure has been very much impacted, is that there must be a plan in place if the local resources are maximally harnessed, but still can't meet the needs of the employee or the person on a mission, then there must be a plan in place to be able to evacuate them. Thank you.
I would just add to that, you know, building on what Dr. Buchimo and Dr. Hauptman had said, that we're seeing this particularly play out with sort of a ripple effect in the fact that, you know, more than 70% of frontline health workers in most countries are women. And so as you're seeing some of the other societal disruptions of COVID, school closures, you know, additional sort of caretaking burdens at home, fear of transmission, there's instances, you know, where families don't want family members who are working in health facilities to then return home at the end of shifts. This is causing sort of a double duty burden. So you already have an over-impacted healthcare system, and you already have the additional strains on the system that my fellow panelists talked about. And then you add on top of that this sort of gender dynamic by nature of the fact that so many of the frontline workers are women, and it really taxes the system's ability to meet both baseline primary needs as well as the additional surge needs that come with the acute infections.
Thank you. You've actually set me up for my next question for Dr. Patel. There have been anecdotal reports of increased stress measured in various terms, as varied as domestic violence rates to dental duress, dentists reporting a higher incidence of cracked teeth due to stress. Stemming from the pandemic countermeasures, how has this impacted humanitarian efforts, and what does the future hold?
So first of all, you know, I should say that, you know, the situation for mental health was already in a dire situation even before the pandemic. I think we have a very broken mental health care system in all countries, and that includes in humanitarian contexts. And I think this applies to all populations, including the wealthy countries. So I think that's the background before the pandemic. I think the pandemic has obviously worsened the need. It's greatly increased the need, primarily because of the enormous uncertainty around the future, about the disease, and a whole range of other factors that I think we're all familiar with. And then I think now, thanks to the lockdown and all the various containment strategies, we have also the very grave increase in the social determinants that actually are recognized to worsen mental health. For example, rising inequality, poverty, domestic violence, and so on. So I think what we're really going to see in the months and years ahead is a massive increase in need in the form of mood conditions, anxiety conditions, substance use conditions, and suicide, built around a system that was already deeply unsatisfactory and dysfunctional. And so I do think this is the next crisis that the world is going to have to face. And this is true of both humanitarian settings, but to be quite honest, in the country that I'm currently in, India, actually, it could be fair to say that huge swathes of the country are facing a humanitarian crisis. About 400 million people are expected to have lost their livelihoods in the last 6 months. I mean, this is more than all the humanitarian populations all assembled. So I think, for me, a more urgent and immediate concern is that as health systems and development agencies around the world are responding to COVID-19, there's almost zero response to psychosocial needs. The response is almost entirely focused on issues like vaccines and diagnostics. And this is a really dangerous kind of tunnel vision here, because the great need of the people in most parts of the world is psychosocial at the moment.
let me just quickly rejoin that. Sorry, Dr. William, I think I'll come because it just triggered what I was actually like the background of when I was preparing for this. And just looking at even the setup of many of our projects, I think basically in the region I come from, I think mental health always has come as a second thought. And it is only as a consequence of what we see in our practice, like it's never thought of before. So once all the mitigation and prevention measures have been put in place, and then you restrict people to stay at home, then you didn't think about what will happen when these people are staying at home. They're working from home. If they have to work from home, you have closed schools. So the parents have children in their house. They have 4, 3, or 5, or even, I don't know. And then there are also other like in most of our setups, we live even with extended family. So there's a lot of pressure on the index people of the house, but we never thought about that when setting up of this project. So this is, I think I agree with Dr. Patel that it's something that in the humanitarian world, we should encourage even the governments that we are partnering with, that this is a core component of every project that we think of. And not just, actually the COVID has only opened up what maybe we were not, we were aware of, but we were not brave enough to take it on. Thanks.
Thank you. I can add that I couldn't agree more with the comments that have been made. And in fact, just within the last couple of weeks, the Centers for Disease Control put out a study that they did on mental health. And this was looking at people in the United States, but for sure, it's applicable globally. And they compared the incidence of mental health in 2020 compared to 2019. And as expected, the increase was dramatic. Looking at depression and anxiety, the increase was 4 to 5 times what people reported in 2019, as well as substance abuse and post-traumatic disorder. And what the article argued for, which is I think what all of us on this panel are getting at, is that this now has to be recognized, just like COVID-19 and cigarette smoking. It needs to be seen in the context of a public health concern for mental health, and not just an individual concern, for communities and governments to have plans in place to be able to support our population globally with mental health services. And clearly at International SOS, the calls that we have been getting mirror what was documented in that study, in that we're seeing a dramatically increased number of calls related to mental health concerns about the pandemic. People's usual support is taken away. If you're anxious and depressed, you spend time with your friends and that makes you feel better. Now we can't do that. So we're fielding a lot of calls globally to fill the hole until public health measures can step up and do what's needed.
Clearly a universal and daunting challenge. Next question for Rebecca. Women typically bear a disproportionate share of any burden and social disruptions. How can we promote access, equity, and quality reproductive, maternal, newborn, and child health services in the face of the global infectious disease outbreak?
Thanks so much. And it's true. And I think, this is a common theme that's starting to come out of this, is that, in many ways, the pandemic has highlighted pre-existing realities and exacerbated inequities or exacerbated strains on the system that were there before, and then they play out, and they've been playing out in a really dramatic fashion over the past several months. And so as we look at sort of the array of women's health needs, and this really does everything from sort of routine family planning services to emergency obstetric care, cervical cancer screenings, and everything else. These were often areas that were under budgeted or deprioritized even pre-pandemic, and yet they are recognized as essential services. And so in any humanitarian setting, including, where there's an acute disease outbreak, we know that we need to maintain those services, and yet the ability to do so has been really curtailed. And we are seeing that, as I mentioned, directly affected by additional burden and pull on women who are often serving in these frontline health worker roles. And we're seeing it as healthcare staff is diverted away from these essential services into ICU units or other sort of acute COVID response within health facilities. So there's several sort of strategies and adaptations that programs I've been working with have been testing and have proved promising. Of course, time will tell from a rigorous evidence standpoint. But some of the things that we've found is that identifying and deploying rapid retraining for recently retired healthcare workers has been one way to meet that shortfall and to get specialists in women's health and maternal and newborn and child health back in. Another sort of, or I would say two other key areas are needing to be a lot more creative with how we're maintaining access to services. So one of these is to make sure that we are able to maintain community-based services. And in many places, particularly humanitarian settings, that has to include mobile outreach or pop-up clinics. One of the things that we learned in the early months is that those weren't necessarily prioritized for PPE. And as the world was sort of experiencing shortages of masks and eyewear and everything else we needed, community health workers, community distribution workers weren't necessarily being included. And it created an even bigger disruption than was necessary. And we've begun to correct for that over the past several months, but I think that's one of the things I would really urge as we look to the future, is that those community workers are critical to maintain access and to maintain essential services.
Excellent, thank you. I see the emergence of a trend here. Everybody's pointing to the need to evolve how we work in the field. Next question for Dr. Abramowitz. You mentioned in your introduction working with Ebola. In 2014 in West Africa, we learned about the primacy of cultural norms and practices. That outbreak was not contained until local customs that spanned generations were modified. How can we build community resilience for this and future pandemics?
Yeah, thanks for asking this question. And I think that when we reflect, we've been basically having a long conversation now for the last 6 years about what to learn from Ebola. And then, it's been really challenging to figure out how to apply those lessons to the COVID context. So the dominant narrative during Ebola was the idea that communities were resisting public health interventions, especially around prevention, right? And in certain key ways that was right, and in certain key ways that was fundamentally wrong. And as time has passed, non-pharmaceutical interventions have shifted from a model of thinking about community non-participation in, public health recommendations during epidemics, as not being resistance, but as being, what is now being called the 4 R's, right? Reluctance, refusal, resistance, and rejection. But instead of saying that's because of customs or because people won't change, we're starting to acknowledge that people do what they do for good reasons, right? During Ebola, for example, burial practices did have to shift in order to meet public health needs, especially around transmission, right? But at exactly the same time, public health needed to shift to meet local capacity and to meet community needs, right? Communities were already mobilizing locally based responses, especially around, for example, isolation and quarantine. And epidemic responders needed to shift to a model of directing communities what to do, to following communities' lead and playing a supportive role. I think during that time, we also started to recognize that misinformation and disinformation were a critical area that needed to be responded to in real time in order to prevent worsening epidemic conditions. To pivot this over to COVID, I think that, the need for social distancing has really exposed the limitations of what we're now calling risk communications and community engagement. Previously, we were calling it social behavior change. We were calling it social mobilization, right? We are seeing, once again, that despite a lot of discussions around non-pharmaceutical interventions, the need to talk to communities, the need to work with communities and to build upon their existing capacities, we're still seeing a lack of capacity at national and local levels and international levels, right? We're seeing a lack of readiness to be mobilized quickly and early, and we're seeing a lack of integration into broader health infrastructure in real time. All of these are really serious issues, right? And we also, and I want to kind of, and I appreciate Rebecca's comment about the failure to provide PPE, for example, to community mobilizers, because what I've observed during the COVID response is that once a dominant narrative was established that community engagement couldn't happen because of social distancing, we stopped planning for the fact that in many countries, it was continuing to happen in the context of COVID transmission, and it was the only option that people had available. Door-to-door, household-based communications were still happening, even in context of lockdown and shutdown. And the health infrastructures were critically dependent on those capacities, but they weren't preparing for those scenarios and they weren't preventing those sort of situations. I also want to reference back to Dr. Patel's comment and just note that community engagement systems and epidemics are often multitasked with, you know, soliciting community support, right? Providing and meeting all informational demands, which are shifting constantly in real time, and frequently providing real-time psychosocial care and support all at the same time, right? So this is an overtaxed, overburdened, underprepared, and undercapacitated system that is providing three very different sets of critical functions in high emergency context. And I also just want to say, you know, without human engagement, just that confers participation, empowerment and ownership, inclusion, two-way communication, adaptability and localization, and building on local capacity, you know, we are fundamentally going to continue to fail to meet our responsibility to provide accountability to affected populations. Now, I just want to, I know I'm speaking on and on, but I just want to say, you know, to respond, what can we do? We need to stop treating community engagement and non-pharmaceutical interventions as a trailing intervention that's introduced to solve problems that were created by the rest of the response. We need to tie them into the response at the beginning. We also need to advocate for and gain national commitments to community level participation and engagement. The IFIs need to start figuring out sustainable mechanisms for financing durable community engagement infrastructures. We need to improve our capacity for real-time knowledge and action. We need to improve funding and capacity flows and understand how they're working better at the coordination level above and below. And finally, we need accountability, accountability, accountability for sort of meeting these objectives. So that's where I'll conclude for right now.
Thank you. Wonderful. We have some great questions coming in, and most of them are addressing either logistics or technology. We'll return to that. But first, I have a human question for Dr. Hauptman. Unlike this conference, humanitarian health services are not really conducive to virtual operations. What are the challenges to reconnecting with the communities that are served, particularly with regard to the humanitarian workers?
Sure. I mean, if everybody is eager and anxious to get back to the field, to get back to work, to the office, and to travel as soon but as safely as possible. And of course, this means understanding where we are, how we got there, and what the new normal is going to look like, and how long until we get back to the old normal eventually. You know, this is a new virus, of course, and when this came about, you know, at the beginning of the year, the end of last year, we knew nothing about this. So it should be reassuring just to think about the tremendous amount of knowledge that's been gained in a relatively short period of time. It doesn't mean that there aren't questions that remain, but we've become so much smarter understanding how the disease spreads. At the beginning, it was thought only symptomatic people. It wasn't even thought it was person to person. Now we understand it's so much of the transmission is with people who are not symptomatic. Is it respiratory droplets? Is it airborne and aerosolized? The The thinking is probably there is some degree of airborne and aerosolized transmission, but that's still being looked at. Obviously, treatments that are available now, learning how to prone people, lie them on their stomachs, different medications like remdesivir and dexamethasone, just learning about the supportive management of these patients we've learned so much. And of course, what we've seen is that even now, while case numbers are going up in many locations, the death rate isn't going up as much, partially because many of the new cases are younger people who are less vulnerable, but also partially because we've learned so much about the disease and how to treat it. So from a medical perspective, health was always a concern for NGO members going on missions, for anybody traveling. But now health has really bubbled up to the surface as to the primary focus. Everything seems to flow from this. If I'm going to go back to the field, you know, everybody has a duty of care to make sure that people are remaining safe as they travel. So we need to use everything that we've learned, everything I discussed before, to mitigate the risk. We need to understand the research. We need to understand the containment and mitigation measures locally. We need to have a means of educating people before they travel and communicating this. There's, of course, an overwhelming wealth of sources of information, not just limited to the CDC and the European CDC and the World Health Organization, but seemingly every hotel chain, every transport organization has their website that will tell you what they're doing to keep you safe. So the key now is to educate yourself so that you can be maximally prepared, choose wisely, and have control over what you can control to allay risk, allay concerns, and in this way inspire confidence. And one of the arenas that we obviously need to look at very closely is assessing the destination of where are people located and where are they traveling to. It's incumbent upon everybody before they send somebody to travel and before you travel yourself to research and fully understand the location. And I'm not just talking about the level of COVID disease, although that's important, but you need to understand all medical risks. We've had so many calls now at International SOS from somebody who's protecting themselves from COVID, but they forgot to take their malaria prophylaxis, and you know, sort of the focus shifted. You know, they're not protecting themselves from mosquito bites, and now they have dengue. So the destination needs to be looked at holistically, not just with regards to COVID. You need to understand what the mitigating measures are before you go. Do I need to wear a mask? Of course, I should wear a mask. Social distancing, is that in place? Do I need to quarantine when I arrive? Because this may impact how much of your usual medications you need to bring with yourself. And we talked earlier about health infrastructures. You need to understand the health infrastructure of the country where you're going. There may be one country that has many, many COVID cases, but the health infrastructure is doing just fine. There may be another country with fewer cases, but it's been enough to overwhelm the health system. So all of that needs to be understood. And really the message is, after you've evaluated the destination, the key, which I think I mentioned earlier, was optimizing your health before you leave so that you can minimize the chances that you'll need to avail yourselves of the health services.
Donald, can I just quickly comment on Dr. Liam? I completely agree. And just as a rejoinder, I think as we do that, I think also the question we should ask ourselves is how much are we investing in the local or national staff? So that if this happens, then services should continue. So I think as we do that, another dimension is also just focusing on capacity building of our national staff, the people we're working with, invest in trainings, at least when such a thing happens, unforeseen emergency, not just COVID, anything else can happen, okay? And then your most resourceful person is stuck either in wherever, outside the proximity of the project. I think we should have a very reliable fallback. So I think this is also a moment of reflection on how do we, change how we've been working, because crises are actually moments of change and they inform us. So we should also draw lines, lessons from such. Just like Rebecca and Sharon, I couldn't agree more about community involvement. And actually, if the community don't have a buy-in, most of these things will just crumble immediately we leave. So we should think also in terms of sustainability, and sustainability will start with the community and also investing in the local staff that we train and capacity build so that we create a more sustainable and robust system that can withstand the test of what COVID has presented to us. And it goes beyond that. Maybe we can talk about supply and in maybe another question, because these are also just like key things that we focus on. So coming with a project is very nice. Having community involvement, it is the key, is more important. They have solution to their problems. They know, they've lived in this community for the last centuries, I don't know. What we need to invest in is how can we support them adapt better and live a better life.
Right, no.
Very good point.
Yeah, thank you very much for adding that. And of course, I couldn't agree more. And I can tell you that I've spoken and I've had conference calls and webinars with so many of our NGO clients. And they've said precisely what you're saying. I mean, they're essentially saying that, you know, you have to help us get back in the field so that we can work with these communities and, you know, and in the fashion just as you described. So I think it's, as always, as it has been, it's a very, and it should be a very symbiotic relationship.
Thank you. Sam, you actually set up my next question. There's actually a story of a military leader who once said, I don't know what logistics are, but I need lots more of it. What do we see? This has clearly shown gaps in the global supply chain. This is for the whole panel. How do we foresee the evolution of not only emergency medical distribution, but just routine supply in the humanitarian world?
One of the things I want to say, you know, from my, you know, just following on from the conversations about the engagement of communities, is also to really interrogate what are the interventions that governments and scientists are actually promoting more heavily. I do think there's a problem here about power. Who actually holds power in global health and in development, and how is that power then translated into the sorts of policy decisions? Let us take just one example, the absurd focus on things like plasma therapy and ventilators has completely hijacked the conversations around COVID for many, many of the poorest countries in the world, when we all knew right from the beginning that the most fundamental strategies were community-based, mobilizing people, creating trust and rapport, you know, disseminating accurate information about risk, promoting mask wearing, and so on and so forth. But instead, the whole agenda was hijacked by a very narrow biomedical technology focus. And I do think this is a problem, and I think we have to interrogate it. And a lot of this has to do with the power of global health and development agencies that have really essentially pushed a very narrow agenda and hijacked a very long-standing tradition that many of us have worked with, which is that of empowering participatory decision-making, starting from the grassroots, all that stuff that for the last 2 decades has really characterized the transformation of global health has been thrown completely upside down by this pandemic. And we really have to reclaim that territory. And so when you talk about supply chains, my first question, my response is supply chains for what? You know, are we going to go back to this conversation about vaccines? Or are we going to talk about supply chains for food, for livelihood, supply chains for basic medical care? Just today in the Lancet Global Health, there is a shocking figure. And this comes from not models full of holes built on assumptions, but actually first-hand observation of a large population-based cohort of mothers documenting the changes in delivery rates in hospitals, in community hospitals, and the increase in neonatal mortality. It's gone up 4 times. Neonatal mortality has gone up 4 times, and this is not a model, this is actual numbers. And you can translate this and count the number of newborn babies who will have died in Asia alone probably exceeds the total global toll of COVID-19. And so I think we really have to pause and think about the absurdity of this response in terms of the complete absence of the voice of the community in thinking about how to manage it. It's not to say that COVID-19 is not a significant and major public health threat. I'm not at all saying that. All I'm simply saying is a tunnel vision of only seeing COVID-19, ignoring all the contextual factors of communities, is an absurdity. And I hope we never see something like this again.
Yeah, I mean, just to build on what Vikram is saying, I mean, I'll just add to what we're seeing in that new evidence around neonatal outcomes. But Guttmacher Institute has done some recent modeling that believes that just in 2020, so just in a 12-month period, and only in our low and middle income countries, and I know this is happening in the US and other higher income countries as well, we're probably looking at, at least an additional 15 million unintended pregnancies, probably more than 3 million additional unsafe abortions, both because there's more unintended pregnancies and because access to care has been compromised. And I, was kind of playing with the numbers and absolutely, what we're going to see. And we saw this in the Ebola outbreak too, that the severe morbidity or the actual deaths from disruption to other care is going to probably equal or at least very closely approach the morbidity and the deaths that are direct cause from COVID. And as we've looked at this, and I'm dealing with this with a lot of the programs I support, and I'll use abortion services as an example, right? I mean, it's a highly sensitive service area because of the political controversy and often the restrictions that are in place around it. Its supply chain is already weak to begin with. So again, we have this situation where there was a pre-existing weakness that then gets exacerbated by the emergency. And in the beginning, there were like 2 ports in the world through which 90+% of manual aspiration devices came through, and they were closed. And so there was a complete shutdown in this entire area of critical life-saving service. Now, where there were places that had done better emergency preparedness, either because of past experience with disaster or, that just had good contingency planning in place, they had additional supplies, either for medications that can provide alternate services, or that had some stock to kind of cushion when this interruption in service happened. But there wasn't nearly enough of that. And so I think, to the participants' question, as we look at the evolution going forward, we really need to begin to think in terms of emergency preparedness, right? I mean, a lot of us who work in humanitarian or disaster contexts know you never have a single staffing plan. You never have just one option for anything because it is a moment of flux and it is a moment of change. But we haven't always been as good at doing that in our supply chain, particularly for sort of the routine or what we think of and like take for granted supplies and equipment that we just use. And I think that's going to have to become part of our thinking so that we're more resilient whenever the next shock comes along.
I'd like to just add in on this I'm sorry, there was a weird audio thing. The supply chain, just to highlight what we were saying about the biomedical focus and the highly technologized focus of our supply chains, all of the global supply chains around these sorts of responses focus almost entirely on biomedical interventions and don't actually take into account at all non-pharmaceutical interventions, right? So if you take, for example, South Sudan, right? They were in a situation in which, they had incredibly limited the RCC task force had incredibly limited access to other kinds of media outlets across most of the country. And just because it's South Sudan and they're basically already at the end of the global supply chain for everything, they had issues getting together, pieces of paper so that they could post, safe like hand washing practices. Forget about soap, clean water, and everything else, right? And there was one sort of exceptional area right along the DRC border where there had already been a lot of like Ebola preparedness work taking place, where those kinds of resources were available and on tap, and some limited media network, social network, work could be done, some mobile network activities could take place, right? But we need to start thinking about the global supply chain as embracing and prioritizing non-pharmaceutical interventions that have the capacity to do prevention, right? And to preempt the need for, a much higher challenge and, much higher cost, supply chain related issues.
Excellent. Dr. Patel, you triggered you triggered a great conversation that actually leads into our next question. Clearly, and you also touched upon one of my pet observations that we tend to be enamored with technology. Yet, if we ignore technology, we may overlook viable solutions. So, from the panel, how does your organization evaluate whether innovative medical devices used in the developed world are a fit for the needs of NGOs? Follow on, it says, what are key criteria when evaluating devices and protocols and their applicability to austere medical environments to improve clinical outcomes?
Well, let me go first then. It looks like everyone's pondering, and I might just speak as I ponder. So I actually am not against, this is not an argument against technology. It's very important for me to clarify that. I think technology is a very powerful enabler, but if technology becomes an end in itself, then actually it comes in the way of actually achieving our public health goals, our development goals. The technology has to be something that is useful for human beings to actually achieve goals and surmount barriers that they were facing. A wonderful example of a technology is preserving the cold chain in vaccines. I think that is a great example of getting vaccines out to the last mile. I think that is a really practical, it's low cost. What I am concerned about is the obscuring of community attitudes, needs, desires, beliefs, and trust at the altar of technology. That is what I'm concerned about. And, I think there's some wonderful work in the US alone to show that, for example, in the US medical system, the singular focus on technology in the form of, for example, electronic health records has utterly ruptured the relationship that a physician has with their patient. So that the physician, those of you who work in the US will probably know this. When you go see the doctor in the US, the chances are the doctor is going to spend more time looking at a monitor than actually looking at you. Now that is an absurd kind of technology. This is like a ridiculous technology. And so that is what I'm cautious about. Technologies have to be in the background, not in the foreground.
I agree with you. And in terms of technology, actually, it also depends on what exactly are we looking at. If it's in terms of diagnostics, in terms of production of medicines or whatever, but just to be like as simple as it can be practical is in the situation that we find ourselves in, specifically this COVID, having worked with the international organization in the forefront, in the field for over 15 years, I think it's unfortunate that the shift normally has been on making our work easier at the expense of the comfort of the patient. So it's a double thing that we have to look at in different lenses and see what are we investing in terms of technology. How good is it for me as the health care practitioner? How good is it for the patient? But at the end of the day, I'll come back to what I said before, like what we are investing in. If it's at a referral health facility, then well and good. If it's at a primary healthcare facility, we look at how can this be sustained in the coming months. But technology in this COVID has helped in terms of coping with the numbers, because you have a surgeon, you have to deal with things quick, making quicker decisions. I think it's a good thing. We embrace it, and like Dr. Patel has mentioned, also cautiously, not to ignore the patient at all.
Excellent, thank you.
I couldn't.
Go ahead, Rebecca.
I just wanted to really echo what Sam just said. I could not agree more. And when I go into a facility to introduce a donated piece of equipment, which is something that happens in our programs, or I'm doing a training, there's a few things that we sort of always check for. One, first and foremost, of course, is it powered? And if so, where is it getting its power from? And how reliable is that power? And, you know, are things like solar panels available? Are batteries available? What are we talking about? I'm sure many of you listening to this can relate to the experience of seeing a beautiful piece of equipment and there's nowhere to plug in its cord. So it just sits there unused, right? That is obviously, when we're evaluating devices, that should always be first and foremost. But then very quickly on its heels, and this comes back to the sustainability point that's been raised, who's fixing it and do they know how to fix it? So often if I'm training somebody on a new piece of equipment, it's not just how do you use this for its diagnostic or its therapeutic purpose, but what do you do when something goes wrong? If this bolt falls off, do you know where it came from? How are you putting it back on? Is that part available in this country or not? And really thinking through that cascade down to that local level, down to that last mile point of use, point of care. And then third, and this really comes back to this sort of client or patient-centered vantage point, is what feedback are you getting from your patients as you've begun to use this new device or new technology? And if you're not getting any feedback, how do we make sure we're getting that feedback? And if you're thinking about adapting or introducing a new device into a new setting, thinking through how you're going to get your patient feedback should be a critical piece of your planning.
Excellent, thank you. We have about 7 minutes left, so I'm going to ask each of you, and I'm in reverse order. In conclusion, what do you see the future holding, and what's your most fervent wish for humanitarian healthcare? Start with Dr. Hauptman.
Yeah, how do I see the future? That's I get that question a lot. Sort of, you know, what's coming next as we continue our effort to come back to the new normal. And you know, we see that operations are going to continue to resume, travel is going to resume, but we're going to see an increased number of cases. I mean, and we're seeing this, unfortunately, now in the news in Europe and around the globe. At least 73 countries are seeing surges in cases, including in the United States. So the situation is definitely going to remain fluid and dynamic, and really there's a continued duty of care to be able to educate and protect people as they in their communities, and the people who come visit them from other areas. And you know, what we advocate, just to maximally maintain the trust of people going on missions, is to have a plan to educate them before they leave as to what the risks are and how to mitigate their risks. Expect the unexpected, because everything's changing very quickly, and everybody's going to need to remain nimble to respond quickly to a changing environment. And this changing environment can be disease levels, health infrastructure, lockdown, stay-at-home orders, public transport, regulations regarding social distancing and masks. So all of that needs to, all that information needs to be readily available, and you need to have a means to disseminate it to all of your colleagues. And then finally, of course, as I said earlier, in the event that evacuation is necessary, you need to have a plan as to how that would be effected. Thank you.
Thank you. Dr. Abramowitz, talk fast.
I'll just say very quickly, I would like to bring everybody's attention to the recently released Global Preparedness and Monitoring Board report, A World in Disorder, which calls for long-term sustained community engagement is crucial for detecting outbreaks early, controlling amplification and spread, ensuring trust and social cohesion, and fostering effective response. I also just want to say that I think what we need to do immediately is we need to start looking to the Global South for answers, right? And not just as a source of problems. Uganda is charting a course of sort of recognizing that they're in a permanent state of response and therefore in a permanent state of preparedness, and they're starting to build that into their infrastructure. Niger has done extraordinary things with social data in the context of the COVID response, tying together, local chiefs to, public health reporting, contact tracing, and information dissemination. I mean, we really need to start looking at where the innovations are happening up and down the globe and start trying to map those onto other places. So I'll stop there. Over.
Thank you. Rebecca.
I mean, I mostly just want to fervently echo what Sharon just said. I could not agree more. And I think the other thing that I really hope is that as we look forward, because COVID is not going away in the near future, that we really look at this as, in a true public health sense, of a social crisis and a social pandemic, not just the infection pandemic. Because without that, we are going to continue to find that our systems are getting in each other's way. Thank you so much.
Thank you. Dr. Patel.
Well, I want to echo and agree with everything that my fellow panelists have just said, and then more specifically in the area of mental health. I think this is a historic opportunity for us to reimagine an existing broken mental health care system for the whole world. And in particular, I want to emphasize the need to look beyond narrowly defined and diagnosed mental illnesses to focus on actions that are preventative in nature, which we rarely ever done in the mental health field, to use a rights-based approach, for example, that eliminates coercion in mental health care. And finally, and perhaps most excitingly, that really focuses on quality of care through task sharing of psychosocial interventions to frontline providers based in communities.
Thank you. Dr. Sam.
In addition to all that, just allow me like three things. First is in this pandemic, as it's ongoing, I think every effort should be taken to ensure cushioning of the most vulnerable. The elderly, women and children actually should be the forefront of their well-being. Secondly, to the humanitarian organizations, I think it's time we adjust and adapt to the new realities, because we have organizations that have been in existence for over 50 years using the same principles in the 21st century. Now, I think it's time to relook at how we approach and how we carry out our operations and the protocols and how we value everybody's system. And lastly, to the governments, I think they should be quick enough to have better coordination and efficiency and ensure that there is community involvement, that we draw projects from community upwards, not vice versa. Thank you.
Thank you. Well, in conclusion, it appears that the COVID-19 crisis hasn't so much identified shortcomings, but highlighted the shortcomings that we've all been living with. Greater coordination, greater collaboration, greater information sharing will be needed. I'd like to take this point to thank the other members of the speakers committee who identified this wonderful panel. Attila Herdalendi from Florida International University and Georgetown University, Elena Cherepanov from Cambridge College, Catherine Kirk, and I'm going to mangle his name, Gian Jose Mazzullo from Pathfinder International, and myself, of course. So thank you, ladies and gentlemen. It was a wonderful presentation, and I thank you for all the good work that you're collectively doing to the world.